Thanks, John, and thank you, and Matthew and Amy, for asking me to come and speak here today. And I'm going to talk about a subject that I've been really interested in since I started psychiatry, is the physical health of our patients, because I think they get a bad deal of this. And also, I think there's been a separation between the way we regard treatment, being clinicians for patients with mental health problems and physical health problems, that I think we need to put back together and regard as one. So I'm going to talk a bit today about the health disadvantage that people suffer from, and some ideas and possibilities that the BRC has supported us in trying to get into practice and to evaluate in this area. First of all, Chris allowed us to look at our own catchment area and really highlight what the mortality gap was. So the sort of life expectancy of somebody with a severe mental illness with a diagnosis of psychosis can be cut down on average. Our average figures are in the region for schizophrenia are in the region of about 12 to 13 years of life lost, which is a huge number when you think about it for an illness that comes on in early adult life. And of course, interestingly, there's lots of biological reasons why this might be, and we'll go through them, but large population studies in Scandinavia have shown that that gap between people with a diagnosis of psychosis and the general population is actually greatest in those people who are not on medications. So whilst medication side effects are a problem that we need to address, they're not the whole picture. And it's across the board. This major mortality gap is driven by physical health causes largely as the biggest cause of death, early death in this group. And it's everything. It's everything that everybody else suffers from, just earlier in our patient group. But respiratory conditions are particularly common, largely because of the very high smoking rates in this group. But obesity, cardiometabolic risk, obesity, diabetes, lipid problems, hypertension are all a major problem, plus endocrinological problems, dental problems, and I have an interest in bone health as well. We know that our patients are kind of 1 and 3/4 times more likely to sustain a fracture, and we know the bone mineral density is decreased, so bone health is also compromised. And there's lots of reasons why this might be. Smoking is the biggest. We have 62% of our people with an established diagnosis of psychosis smoked in the last impact study we did, which was supported by NIHR and the BRC. But sedentary behaviour is huge, with people spending maybe about 9 hours on average of their waking day sedentary, and far less likely to meet the national guidelines for how much physical activity we should take in the daytime. And nutrition, I'll come back to, and medication side effects are obviously a problem, because many of the medications can cause increased appetite and therefore increased weight. And there's also illness factors. And in fact, one of the big problems with having a mental health problem such as psychosis is that when it's active, it can interfere with your ability to organize yourself and to communicate. So it indirectly interferes with your ability to self-manage your physical health, which means that you may be more reliant on the system to manage your physical health, or help you manage your physical health. And of course, that means our services need to be adapted accordingly, and that isn't always the way as yet. But they need flexibility, adaptability, and communication, and we're working hard to try and make that happen, but it really needs more work. So do we know how to improve health? Well, Anne McNeil and Debbie Robson and Mary Yates and company in SLAM worked and analysed the effect of introducing the smoking ban that we had across SLAM, and contrary to people's expectations that it might increase violence, actually violence rates decreased on the wards, and this is now an accepted part of practice, having been quite controversial when it started out. More widely, there's been recently a study report called Scimitar, which shows that with tailored smoking cessation support in the community, that people with severe mental illnesses can come off cigarettes. Because when you compare that 62% rate in our patient group to the 17% rate in the general population in the UK at the moment, that's a massive difference, and we need to do work there. We did an NIHR-funded program study looking at setting up a randomized controlled trial, training up care coordinators to work differently with their patients as an integrated part of care. But we found that in people with established psychosis, we couldn't readily reduce their cardiometabolic risk, and this is difficult to establish into routine practice. So, that cardiometabolic risk is difficult to reverse has been found in trials across Europe as well. It's not just us. But we do find that cardiometabolic risk tends to kick in early on, within the first year or so. And we did a first episode study alongside as part of the IMPACT program, showing this, finding that lifestyle factors at baseline didn't really predict who was going to have major trouble with cardiometabolic risk a year later. But what we did find is that there seemed to be different patterns of cardiometabolic risk emerging, whereby white males were more inclined to put on weight around the waist. Waist circumference is a predictor of cardiometabolic risk. And we also found that the people who developed a dysglycemia, so their blood glucoses were going up into the worrisome, not diabetic range, but the pre-diabetic range, according to American criteria. That rise was largely driven by rises in our people of black and ethnic minority heritage rather than our white patients. So this is an area that we need to do further work on, a potential inequality. So the key message is that health promotion and indeed secondary prevention and keeping the body in mind is needed right from the start. And how do we integrate that into practice, and how do we get the evidence to inform that practice? So there's some things we're testing to see will they improve health outcomes. As part of that impact study, we looked at vitamin D. It's important in bone health, but also cardiometabolic risk, and also in how your brain works as well. But it's low when you first present with psychosis. It's 3 times more likely than the general population, age, sex, and ethnicity matched controls, to have low vitamin D deficiency. And in the weeks, and actually the lower your vitamin D is at presentation, the higher it was associated with higher total psychosis scores and negative symptom scores a year later. But we still don't know whether giving vitamin D will help. So at the moment, we're conducting a trial of vitamin D in early psychosis, and we're hoping to report on that next year, so that we're going to be able to answer the question, will giving vitamin D in the first for 6 months in people with early psychosis improve outcomes in terms of primarily their mental health, but also their physical health as secondary outcomes. And we'll come back and tell you what the result of that is later. And of course, exercise is hugely important. I mentioned sedentary behaviour, and we've done some work in terms of walking groups in the community as well. But when people are stuck in an inpatient unit, actually getting an exercise program when they're just starting medication and their appetite is increasing, well, can you do something to increase their exercise? So Rebecca Martland is working with Brendan Stubbs and Juliana O'Murray and looking at high-intensity interval training, do a feasibility trial as part of a PhD funded by the BRC to see whether it's feasible to introduce static bikes within a ward setting and assess the effect on people's, whether people will adhere to that, whether people will be keen to take part in the first place, and then give us enough information to be able to plan a larger study to see whether this will actually help in terms of reducing cardiometabolic risk and preventing the emergence of physical health morbidity down the line in this group. There's also, the BRC have also supported us to think differently about things and work across systems. So we're learning from the eating disorders team, and they've been doing great work in terms of binge eating and food cravings. And what happens when you go on antipsychotics is that it increases your appetite, and you may experience food cravings, and indeed you may wish to eat the sort of sweeter and high calorie and saltier food. So people can put on a lot of weight very quickly. So Louisa Gritchik, and along with Ian Campbell and Ulrika, are working on people who are taking antipsychotics, and to see will a combination of techniques that they've used in the eating disorders field help people change their attitudes towards food, and in particular towards their food cravings. So what we're doing is using approach bias modification training, which is a computer-based implicit learning paradigm where people use a joystick when they see pictures of particular types of food on the screen. And that's postulated to gradually change the way you respond to different types of food. And they were combining that with either real or sham transcranial direct current stimulation. The idea being that combining these will allow the learning from the computer paradigm to be able to be sustained into one's day-to-day life and hopefully then affect one's control over one's eating habits in this way. So again, this is a feasibility study at very early stages, and Louisa has just started recruiting. I don't know if she's here, but we're hoping to be able to check its feasibility and again gather preliminary data to be able to set up a larger study. The BRC have also produced tools that we can use to potentially introduce into clinical practice and to help in terms of physical health. CogStack was developed by Richard Dobson and his team, and what we're doing now as part of the BRC, and what we're doing now is working with Dipen Patel, who's one of our doctors here in SLAM, to see could we introduce the use of CogStack as a real-time prompt into clinical practice to better pick up and manage when people's blood sugars are going in the wrong direction, prompting when we need to test, prompting when we need to act or how we might act, prompting when we need to test again, and prompting when people follow up, and with a clear protocol in place to see when people may need to be referred for additional to next line recommendations to another team, for example, or to specialist care. So at the moment, this is an implementation project looking at the feasibility of doing this in clinical practice, and we're just setting this up to see can we improve clinical care as part of a BRC innovation. So overall, there's lots happening. The physical health of people with a diagnosis of psychosis has been a clinical and organisational priority at local and national levels for quite some time. But there are real and multifactorial problems to come across, and a lot of joint working needed across separate systems. And we need the research evidence to be able to inform how we might do this best. So obviously health promotion is hugely important. Smoking cessation, exercise and diet, attention to these across the board is important for all of us, it's important for all our patients. But how we manage to pull this into practice reliably when people maybe don't have leave to get off the ward, etc., is something we need to think about. How we look when we're managing somebody's mental health, keeping their physical health in mind as well, making sure that we have a conversation about side effects, of tolerance, and making sure that people are on the best medication for their mental health too, because that helps them manage their physical health. Looking at equity of access, flexible approaches, and then being aware that actually those people who sign up to research may not be those people who are most at risk, because the people who are very much at risk, maybe not engaged in mental health services, maybe self-neglecting, may also be neglecting their physical health as well. So how do we extrapolate and explore tools to be able to extrapolate from the data we have to be able to find out what is the best way of helping provide equity of care there too. So manage mental health and physical health early for best outcomes. And I think I need to finish now to keep to time, and I want to thank my funders very much and acknowledge my declarations of interest, and to acknowledge that I couldn't even try to write down everybody who's been involved in all these projects, but there's many teams and you know who you are, and thank you all so very much. Thank you.